Okay, good afternoon everyone. Today we will finish our discussion, our final topic in bioethics. Okay. Unfortunately, I was not able to meet with you today because of unforeseen circumstances. No, I was asked to compile the exam papers of my anatomy and physiology class and Dr. Lam's anatomy and physiology class and Dr. On's anatomy and physiology class. So that is the reason why I was preoccupied, no? So today we will discuss the four major bioethical principles. Now I really wanted to discuss this with you face to face because this is a very very important topic. Okay, magbalik-balik ni siya gawas. It keeps on recurring, especially in the board exam. Okay. So first is our respect for person. Now we already know what we mean when we say respect for person. No, it means how we treat a person, how we look at a person, and how we number one, another is how we revere a person. Revere. Okay. Now there are a few aspects in our respect for person. The first one is autonomy, which means acknowledging diverse cultural perspectives on autonomy. When we say acknowledging diverse cultural perspectives on autonomy, what we mean by that is even if we have biases against a specific culture, let's say for example we have a bias um, let's say for example yung mga natives, like native Filipinos, okay, let's say we have a bias against them. Okay, that's understandable po, no? We're not perfect. We have our own cultural backgrounds po, and maybe we might not be fond of other cultures. Okay, but when we say respect for person, no, we will, despite their cultural perspective or their culture, no, we will still have to respect their autonomy or their what we call decision making process, or their right to make a decision. Okay, which may vary in the degree to which the individual's decisions are valued. Yeah, that's the basic point there is in vary in the degree to which individual decisions are valued, no? Maybe a person of a different race or different culture, maybe you vary their opinions much less than a person of another culture. Not this does not only mean culture, no? We also have to consider socio-economic status as well, no? Maybe you don't value the opinion of someone who is below the poverty line, while you value the opinions of those above the poverty line, no? Aside from that, we can also consider in this segment educational background, no? Maybe you will not value the opinions or the decisions, or you will not value the decisions of a person who has not graduated high school, but you value the opinions of those who has graduated a postgraduate degree, like a doctorate, no? So the lesson here is this: respect for person, without bias, we should respect their right to autonomy, or their right to choose, because as a nurse, no, we are impartial. When we say impartial, we're not supposed to have a bias against any and all cultural, socio-economic, and religious beliefs. Aside from that, no, it may be other factors as well, such as educational background, maybe gender even, no? Okay. Next, another code is informed consent. Now we've already discussed informed consent before early on. It will highlight the challenges in obtaining meaningful consent, particularly in vulnerable populations. Now, what we mean when we say vulnerable populations are those who are mentally ill, pregnant, children. Those are vulnerable populations, no? Not to take any away from them, they are not a lesser part of society. More so, they are just a vulnerable part of the society. Okay? Now, how does it highlight the challenges in obtaining meaningful consent. Now, here's the thing you have to remember. When obtaining consent, it has to be obtained from an adult of sound mind and sound decision making. Okay? They must be conscious. They must know what they're going into. They must know what they are consenting, and they must be a party who can consent. Namely, they are adults. Okay? Now, the age of consent here in the Philippines is 18 years old. 18 years old. Now, in order to qualify for consent, they must be of sound mind. When we say sound mind, they have no mental disabilities, disorders, so on and so forth. They must be conscious, and they must be, what do you call that? They must be, sound mind and sound decision making. What we mean when we say sound decision making is that they are not being forced. They are not being forced into doing or into this decision. They are not being coerced into making this decision. Okay? That is what we mean when we say sound decision making. Now, that is consent. Now, in vulnerable populations, there are problems there specifically. Let's say, for example, in the in children, no, in children, it highlights the challenges because children are not able to give consent. No, we have to take consent, or we have to get consent from their right next to their next, okay, no, not next, from their parents, no, from their parents, or maybe even their guardians. Now, another is for those who are mentally ill or emotionally ill. No, maybe they have maybe they don't have a sound mind, no, so that their decision making process or their cognition is not good enough, or not particularly fit in order to make a decision, no, especially concerning hospital. Usually when we take informed consent, this is for procedures involving mostly invasive procedures, so it is a very high regard, no, in the hospital. Respect for persons also delves into our patient rights. You remember the patient's rights, diba? It's in your ID. Okay? We are now in patient's rights now. We are going to be exploring the ethical implications of balancing patient autonomy with considerations for their best interest. Now, always remember this: the decision of the patient might not be for their best interest. Okay? Their decision might not be for their best interest. For example, maybe it is in their best interest to get this surgery, but the patient decides that they don't want to get this surgery. Now, in this instance, no, we have to respect the patient rights, respect their autonomy, because they are the ones who are truly in control of this situation, no? They are the ones who will be the ones to decide whether or not to undergo a certain procedure. Okay. Next is justice. Justice is we have already talked about this, no? Justice has two points. It is fair distribution and equal access. When we say fair distribution, addressing the global dimension of justice, including access to cutting-edge treatments and therapies. Now, when we say fair distribution, class, no, it is distribution that is available to most of the population. And without bias. That's why it's gonna be fair, without bias. Now, here is the thing you have to remember. Okay? There are new cutting-edge technology and treatment going on around the world. Okay? Maybe there's a new sort of experimental treatment that is mostly going to work, okay? Or is designed to work fairly well. Okay, when we say fair distribution, class, most of the time when we say cutting edge treatments, these are only available to those who are higher in the socio-economic or social standing, no, kanang mga dato. Okay, so cutting edge treatments usually they will be the ones who will be able to use it. No, when we say fair distribution class, this treatment should be available for everyone. Everyone. That's why it has a global dimension of justice. Justice, when we say justice, it is equality between people. Okay? Where is the justice? Where is the balance between good and right? Where is the balance between what is right and what is wrong? Okay? Next is equal access. Equal access is similar to your fair distribution. This is commonly seen in your CHN. It is recognizing the role of socio-economic, racial, and geographical factors in healthcare disparities. That is the main key there, the healthcare disparities. Now, how can you say that there is a healthcare disparity? A healthcare disparity is, you can see it because there is a problem with the method of delivery of healthcare. Now, sir, why is it a problem? Why is there a problem regarding equal access when it comes to healthcare disparities? Simple class. Let me tell you this, okay? Let's say, for example, you work in a hospital. You work in a hospital. Now, when we say equal access, anyone, regardless of age, culture, background, anyone should be given a fair and equal level of service. Anyone should be given a fair and equal level of service. Now, what do you mean we say socioeconomic, sir? Okay, sometimes in the hospital, no, we do not admit, let us be fair or let us be honest with ourselves, no, there are hospitals who do not admit patients who are not financially stable enough to afford medical care. There are hospitals that will not allow the admission of people who are not stable enough for healthcare. Now see, that's the problem. Because now they are filtering. They are only allowing those who can afford healthcare. Now, where is the equality in that? Okay? Where is the equality in that? As I've said, no, our healthcare system should receive any and all people regardless of age, sex, culture, so on and so forth. Okay, how does race come into it? When we say race class, no, there are some hospitals, as I've said, no, they choose, they still practice, no, what we call they still practice like separation nito, like what about divide, they will divide the races, no. This is more common in the US, not so much this in this modern age, no, but maybe in the older in the past, no, they try to segregate different races, no. That hampers our equal access as well, because as I've said, no, hospitals should receive any and all people despite their blah 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 blah. And lastly is geographical. Now this is one most common in the Philippines. Okay, when we say geographical, it refers to the actual location of the healthcare facility. Okay, now let's say, for example, in the city class, there is lots of hospitals in the cities that allows easy access to those who are in need. Okay, whereas in the community, or let's say in the mountains class, there might not be a health care center for miles. Basin walay health center diha. Maybe there's no health center for the next 50 kilometers. Nga na. Now, there are still people living in the mountains, same as there are people living in the city. But their access to healthcare is not equal, because those in the city can easily access healthcare due to their location. Whereas those in the mountains, they cannot access healthcare immediately because of their location. That's why, class, here in the Philippines, we have satellite healthcare, healthcare, satellite healthcare, or healthcare stations like atong mga barangay health center, like our barangay health centers, satellite health stations or barangay health centers, so that we can diversify geographically our placement, no, of our health center, so that we can provide equal access to the entire population regardless of geographical position. Okay? Injustice, class. Injustice. There are also what we call, as I've said, no, healthcare disparities. In healthcare disparities, class, we should analyze the root causes of these disparities. Analyze the root causes and of these disparities and persistent challenges in achieving healthcare equity. Okay? We should analyze the root causes. Usually, the root causes are found within these three, but there could be other factors. Okay. And also, in fair distribution, we have allocation of resources. Okay. Allocation of resources. Now, when we say allocation of resources, we have to remember. We have to remember. Okay. We prioritize those who need it the most, not who we want to give it to. Okay? When we say allocation of resources, we prioritize our resources to those who actually need it, not to those who we want to give it to. Okay? Next is non-maleficence. Non-maleficence, class, is very simple. It is to do no harm. Do no harm. Evaluating the complexities of harm, such as physiological harm in mental health interventions or unintended consequences in public health initiatives. Now, sir, what do you mean when we say do no harm? Okay, basically, class, when we say do no harm, one of the common examples there is using or doing proper techniques. Okay? Proper techniques, like let's say for example, you are properly preparing a medication. If you do it properly and if you do it step by step using our nursing actions, no, or our nursing step by step guides. If you do this procedure step by step using our nursing guides, no, there will be no harm involved because we have already taken steps, we have already taken extra steps to prevent harm from happening. Like let's say for example, I am preparing insulin. I triple check it so that I do not overdose it or underdose it, and in turn I prevent or do no harm. I prevent harm. Okay? In non-maleficence, class, there is also prevention of harm. Considering the ethical implications of preventive measures, especially when they infringe on personal freedoms. Okay? Especially when they infringe on personal freedoms. Now, class, how do we mean by when they infringe on personal freedoms? Now, when we say prevention of harm, class, some of the actions when we say prevention of harm could counter or be of the opposite of what a patient really wants to do. Okay, let's say for example, a common example of this is when a patient has a seizure precaution, normally or according to protocol, no, we should raise the side rails so that they don't fall. Okay, if the patient has seizure precautions, the normal procedure there or the common procedure there is to raise the side rails so that they will not fall. Now, in our action here, no, it is to raise the side rails and keep the patient in their bed. Okay, so that they will stay in their bed. But it infringes on their personal freedoms because maybe they don't want the side rails to be raised. Maybe they want it to be down, and maybe they want to walk around. Okay? Walk around. Oh. So that is what we mean when we say, especially when they infringe on personal freedoms. But most of the time, no, when we say prevention of harms, usually it is more beneficial than its other effects. Okay. That's why, class, no, in nursing, no, we are gonna delve into the balance, no, between therapeutic benefits and potential adverse effects. Okay, potential adverse effects, because if the benefits, or if the risk or the adverse effects outweigh the benefits, then it could possibly do harm. Lastly is beneficence. Beneficence is the opposite, not the opposite of maleficence. It is more so a synonym. But the difference there is, in maleficence, it is doing no harm or preventing. Whereas beneficence is promoting well-being or doing good. Doing good. Okay? Discussing the subjective nature of well-being and the challenges in divining what constitutes a benefit. Okay? What constitutes a benefit? In our practice, no, basically, what this means is patient-centered care. Patient-centered care, no? Examining the role of our cultural competence and the preferences of the patient in defining what constitutes a benefit for them. Like, for example, class, no, maybe I want to give them a medication. Okay. This medication has a benefit. Yan na a benefit. Let's just leave it at that. Simple. But maybe this might not be a benefit to the patient. Okay? Because they have their own preferences. Okay? Let's say, for example, you are giving the patient a medication that will enlarge their penis. Okay? Enlarge their penis. But maybe, we can see that, no, maybe it is a benefit, no, but maybe for our patients, no, it is not a benefit to them. Okay, it is not a benefit. So the principle of justice once again applies, no, and they have their right to autonomy, or the principle of respect for person. No? We have to respect their decisions, no, but usually when we're saying doing good, no, it is mostly about the benefits. Okay, basically about doing something to benefit a person. Another factor when discussing beneficence, no, beneficence is balancing risk and benefits, addressing the ethical considerations when benefits are uncertain or potential harms are significant. Now, class, no, in hospital we really want to do good. Okay, now one example of doing good is giving medication. Okay, when you give medication, they will be their illness might be treated, no, that is a good benefit. It might be treated, but we have to address though that sometimes maybe there are potential harms or in medications, no, in our side effects. Okay, maybe these side effects, no, are too potent or too harmful to the patient. So that's why we have to weigh the or balance, no, the risk and the benefits. We have to we and the healthcare team, no, we have to properly gauge whether or not to give treatment considering the benefits and the risk. Okay? And lastly, class, is the interplay of principles, no. First is our interplay of principles. Simple, class, no, when we say interplay, class, it is an illustration of ethical dilemmas. Like, for example, class, let me give you an example of ethical dilemma. A terminally ill patient, yan ang padung namamatay, wishes to discontinue life-sustaining treatment. Gusto niya niya ang life-sustaining treatment against the advice of healthcare workers. Once again, I will repeat, a terminally ill patient wishes to discontinue life-sustaining treatment against the advice of healthcare providers. Now, No. As healthcare providers, we have to respect the patient's autonomy. Okay? We have to respect the patient's decision and therefore we will do it. But, listen, our action here, which is to discontinue life-saving or life-sustaining treatment, is in direct conflict with the healthcare team's duty to prevent harm. Okay? Our action here, okay? Our action here is in direct conflict with the healthcare team's duty to prevent harm. Okay? So now the respect or autonomy, the respect is now in direct conflict with our non-maleficence. Okay? If that is the case, class, then what is that is what we call an ethical dilemma. Okay? We want to respect their decision. We want to respect or we will respect their decision to discontinue life-sustaining treatment even if it is the indirect conflict with our duty to prevent no harm. Okay? Do you understand? Yeah. Now, lastly, there's also trade-offs. Trade-offs. Okay? An example of trade-offs is this. When we allocate limited organ transplants to patients based on factors such as age and overall health, this may create challenges in respecting equal access. What do you mean by that, sir? Let's say, for example, you have two patients. How many patients do you have? You have two patients. Both of these patients require open heart transplant or heart transplant. Okay? Now, the difference here is this. Both patients need transplant, correct? The difference is one is 80 years old and another is 20 years old. One is 80 years old, 80, and another is 20. The problem there is this. Okay? Some healthcare teams, they have a bias against, or they might have a balance for those who are younger. Like they might say, oh, let's just give a heart to someone who is younger since they can live a lot longer. Okay? They can live a lot longer. But some healthcare teams, they give bias to those who are older, no? Let's give the heart to this older gentleman because maybe he has something more to live for, no? Or maybe he has not something more to live for, no? Maybe he has some unfinished business, no? Or something like that, no? It really depends. Okay. Now, since we are picking patients, no, choosing patients based on factors such as age, no, there is no justice there. Okay, there is no justice. There is just bias. It creates challenges, no. It creates challenges specifically against what we call justice. Okay, it creates challenges against equal access. Okay? Because no, our action no is very good. Our action is we want to transplant patients. We want to give transplants to patients based on their age. Okay? Giving transplant is beneficence. Okay? When we say it's because of their age, no, it is justice, no. Justice, okay? There is justice there. Specifically when we consider when we actually choose properly, okay, but it may create challenges, no, in respecting equal access, no, because access was chosen based on a metric that was irrelevant to their actual condition, no. It was irrelevant. The way we chose was based on age, no. Maybe let's say 20 na lang, let's say 20 na lang. If it's 20 years old, they have a lot more to live for, no? So the heart will be put to good use, no? not based on their actual condition, no? So the trade-off there is gikan sa beneficence, from beneficence and justice, no? um, it will now go towards, no, respect and justice. It will now go towards respect and justice, no? There's a trade-off. We are now trading off beneficence for respect. Okay, that is an example of a trade-off. Okay, and that is it.